Hi everybody, I wanted to go ahead and record these lectures for you so you'll have them to go back and review. Since I will not be in class tonight, we're going to go ahead and get these done now and I will get them posted. So chapter 18, this is about the labor at risk. What are some things that can go wrong during labor and how do we manage those things that go wrong? Okay, now let me see. To go. Okay, so labor at risk, sometimes there are like situations that can happen that are going to put mom or going to put fetus at risk. So we have to be aware of those and be prepared to act very quickly when something changes. That is why sometimes people will choose to go ahead and deliver in a hospital via doing it at a home birth or maybe a birthing center, because if there's complications, the hospital has everything that is needed to be able to address the issues. If you're at home and you run into fetal complications or fetal hypoxia, you're dealing with a lot of time to get the mother from the home to the hospital to, a delivery room. So that's why a lot of women do prefer to do it in a hospital setting. So education is going to be very important. This will be part of their birth plan. It'll be something that the physician will talk to them about, pros and cons of both. Nurses need to be aware of all the signs of labor and complications that can occur so we can be prepared for those and we can really identify those early before they get to the point where we've got some severe complications that we need to deal with now. Okay, of course this isn't going to work. Okay, so dysfunctional labor or dystocia. Dysfunctional labor just means that labor is not going as we would like for it to progress. Dystocia, totia means labor, dys means difficult, so this just means a more difficult labor, and there are certain reasons that someone might have a more difficult labor. So a couple things that can happen is when labor gets abnormally slow and it's really not wanting to progress like we want it to. So things are just like really going slow. They're not effacing, they're not dilating like they should. So something that is going wrong is going to be something with your 4 Ps. Either the passageway is not appropriate. Maybe you have a small pelvis. We call that cephalopelvic disproportion or CPD. Or it can be from maybe mom's got a disease or an injury in the passageway that's causing that to occur. It could be the passenger. So maybe the passenger's in malposition. Maybe the fetal lie is off. Maybe the mom is diabetic and she has a macrosomic baby. Maybe there's an anomaly with the baby. Maybe the baby has hydrocephalus and that the skull isn't molding like it should. Maybe there's a problem with the sutures and the sutures aren't allowing it to overlap. Maybe there's a problem with the powers. Maybe the contractions are hypotonic and they're insufficient in quality and quantity to be able to really contract that uterus down. Sometimes it's just pure exhaustion from pushing. The moms just are like, I can't push anymore. Sometimes it's a psyche problem. So maybe they're fighting and they're kind of tense about it and they're not able to give those contractions what they need. Most likely it's all of these things, or it could be 2 of these things. It could be maybe we've got the passageways, mom's got a small pelvis, and maybe the baby's in malposition. So we got maybe a couple of things that could be going on with that baby. Okay, so complications. What can happen if mom's labor is dysfunctional or things are not going good? So complications, we can have increased maternal and fetal morbidity and mortality. So we know that the longer mom labors, the longer baby's in there, the more hypoxic the baby's getting as those contractions are not effectively doing what they need to. And it's stressful for the baby during labor, just as much as it's stressful for mom. So infection. If the membranes are ruptured, we do worry about infection ascending up into there and causing like an infection inside they can get like chorioamnitis, or the baby can get the infection itself. Neonatal pneumonia, a uterine rupture. If that uterus is just contracting and contracting and contracting, sometimes the uterus can rupture. Very, very unlikely, but can happen. That would, maybe they have a need for a cesarean section. There can be a fistula that can form. So sometimes you can get a fistula where you get like an opening between maybe the vaginal canal and part of the colon, something like that, where it just wears in there. You can get a pelvic floor injury. So it could be like a hematoma in there. As the baby's coming through, it rips or tears the cervix, and there could be a hematoma forming inside there. So, you know, sometimes hemorrhaging can come from something like that. So those are things that we would need to look at. The manifestations that we're going to see and how we're going to diagnose that, it's usually going to occur in that active stage. So you got that latent stage where, you know, mom's feeling pretty good, everything's going well, baby's, you know, we're still early on, we haven't really got into those, you know, we're less than 4 centimeters. This is going to be an active labor where you're 4 to 7 centimeters, or the second stage where mom is actually pushing. That's where you're at the 10 centimeters. So this is where it's going to be really important to you to recognize what is normal and recognize what is abnormal. So we're going to talk about what would be normal and what would be abnormal. So for a prima para, that is a mom that's never had a baby before. The length of that latent phase of labor, so that's that beginning phase of labor, that is where mom is just really getting started. It usually is less than 20 hours. I've seen it more than that, but it's usually less than 20. If mom has had more than one baby, it's usually less than 14. But a prime-ep, sometimes it can take a lot longer to get through that latent stage and for that cervix to know what it's supposed to do. It doesn't really know it's supposed to efface. It doesn't really know it's supposed to dilate. So we kind of got to, the powers have got to do their job along with the baby and the passageway to get that, all those things to happen. Expected rate of dilation during active labor, so that is that active labor phase, is usually about 1 to 2 centimeters per hour. So it is frustrating for those moms when they check them and they're 5, and then they check them again and they're like 5.5. And they're like, it's supposed to be 1 to 2 an hour. That's ideally, but that's not always what is going to happen. So expected rate of descent of the baby during that active stage, that baby should also descend at least 1 centimeter an hour. So those are all the things that the doctor's going to look for. You know, how many hours have they been in active labor and how much have they dilated? How much has that baby descended? What is their station now? Their station should slowly start to descend. It's going to happen quicker with your moms that have had multiple babies. So just keep that in mind. Causes of dysfunctional labor. One is if the uterine dysfunction. So that's going to be something with your powers. So that is either hypotonic or hypertonic, just what hyper and hypo means. One is going to be not hard enough, and one is going to get into a hypertonic state, and it's going to keep contracting, and then that can cause some problems with our babies. This can result in a precipitous labor, so we want to always watch that. So another thing that can happen is cephalopelvic disproportion, or CPD. CPD just means that the mom's pelvis is really not going to probably accommodate, or the baby's going to have to really work its way into that pelvis to get through. And then fetal malposition. Sometimes, again, when we talked about that fetal lie and those positions, the brow position, maybe the baby's in occipital posterior, and it's not allowing, the baby's not coming down like it should. It's not completely vertex. Maybe it's shifted to the side or something like that. So how are we going to fix dysfunctional labor? Well, a couple of ways. If we have hypotonic labor, so our contractions are not contracting like they should, we're going to augment that. Augmentation just means that we're going to add something to it to make their body have stronger contractions. And usually that's going to be oxytocin. So we're going to increase some oxytocin, get that labor to really get going. Sometimes if we get into hypertonic, so we get into hypertonic labor where the contractions are just like really intense. They're lasting 90 seconds and they're coming just constantly, one after the other after the other. Then we're going to give them what we call a tocolytic, and that's going to stop labor. So we will give them something to stop that labor, and then we can sometimes manipulate that baby We can change that baby's position, kind of push them up where they need to be, change their position to help that baby come through that birth canal. So those are a few things that we can do. I'm not sure if it talks about it later on, but sometimes the doctor can do what we call a version. And this is where they can flip the baby if it needs to be in a different position. So sometimes the doctor will give moms some medicine, and we will watch that baby's heart rate, because it's going to be really important to watch that fetal heart rate, but we can actually flip that baby or turn that baby. It's called a version. Especially we do that with moms that have breech babies, and the moms want to try a version first. Sometimes versions will work, sometimes they won't. Sometimes the babies are just too big to have a version, and they just won't flip. Okay, so nursing care. So what are you going to do for these moms that have dysfunctional labor? Well, we're going to continue to monitor their vital signs and their contraction patterns. If their contraction patterns are poor or they're too much, we're going to have to notify that physician to get some orders to do something to either increase or decrease those contractions. We're going to monitor that fetal heart rate. And we're going to monitor these moms very, very closely. Like every 30 minutes, we're going to be looking at that fetal heart response to those uterine contractions. So you're going to be looking for those decelerations or the variable accelerations, all those kinds of things. Make sure we're monitoring mom's pain. Keep her pain in as much control as we possibly can. Use as many non-pharmacological things as you can do. Make sure you're documenting everything. It's really important to make sure that we document everything so we're catching something if that baby starts to have a poor outcome. Notify your RN or your healthcare provider if anything slows down or gets too progressive. Check that bladder. We know a full bladder can cause labor to slow down and not progress like it should. So we want to either do a catheter or do intermittent catheterizations. Always suggest position changes. We'll put them from left, center, right, center, left. We can get them walking, get them bouncing on a ball, put these wedges between their legs. Anything that we can help get that baby to descend down. Gravity, help that mom get that gravity to get that baby down. Malpresentation. So if we got a malpresentation, most common breech or shoulder presentation, that's going to be that that transverse lie. Things that might cause the baby to be in malpresentation. Moms that's had multiple babies, there's a little bit more room in that uterus to kind of move around. If you have a placenta previa, remember the placenta previa is where the placenta is over the top of the cervix. So then that baby, if the cervix is here, that baby can't come, and the placenta's here, that baby can't come through there. Hydramnios, which just means too much fluid, small pelvis, and uterine abnormalities. If we have a uterus that has maybe bicorticate, which means it has two sides, and maybe one side's real tiny, and sometimes that there's not enough room in there. So that sometimes, if we have uterine abnormalities, that can cause that. I did talk about the versions. Sometimes the doctors will try to flip those babies, especially if they're breech. Sometimes it works, sometimes it doesn't. So sometimes what we can see is, and I think I talked about this, I had a picture about this, frank breech is just when they're in that, when their butt is the first thing down and their legs are completely up. It's kind of like in a pike position. Complete breech is where they're sitting like Indian style, like they're sitting Taylor style, Indian style. Footling or incomplete is one or both hips are flexed and we got a presenting part. So we usually can determine what presentation that baby is by the Leopold's maneuver, by ultrasound, or by just feeling. So we usually can tell those by those types of things, especially if mom just comes in and we do it. So treatment for malpresentation, cesarean section, and an external version like we talked about. Nursing care, monitor that mom. We're going to do a non-stress test. We're going to do a biophysical profile. We're going to make sure we position that mom really well, have other equipment available. Now, if they're going for a cesarean section, we're going to be preparing them a lot. We'll talk more about a cesarean section later. But if you're trying to do a version, versions can be kind of scary. Some women choose not to do them because it is kind of painful to have aversion. It can also cause distress in the baby. If the cord is somewhere, we can get cord compression. So that's why we want to make sure that we are monitoring that baby really closely. So after we do aversion, we're going to do some testing on that baby, some biophysical profile, some non-stress tests, just to make sure that our baby's okay. Premature rupture of membranes. This is where we have rupture of membranes before that baby is before the baby is less than 37 weeks. So that's going to be considered premature rupture of membranes. So we want to make sure we're aware of that. Some membranes completely rupture and they get the large gush. Sometimes it's just a trickle that comes out of there. It does depend on which one it is, how the doctor may manage that. But in both of these, they're going to present with either leaking or they're going to present with a gush of fluid from the rupture of membranes. So we're going to want the biggest thing about ruptured membranes. One, we want to make sure that the cord is not in the way, because remember that amniotic fluid cushions that baby, prevents that baby from hitting that pelvis really hard. And once that membrane is ruptured, there's no protection in there for the baby. So anything that is in the vaginal canal can ascend up in there and get to that baby. So one of the biggest things we want, as soon as the membranes rupture, the biggest thing we want to look for is cord. Make sure the cord's not in the way or dangling out of there. But the second thing is going to be infection. The longer that mom goes with ruptured membranes, the more chance of infection. So we're really going to monitor her temperature, like very, very frequently, like every hour, every 2 hours. Monitor that temperature. Start to look at your trends. Are they starting to rise a little bit? Because that could be very dangerous for mom and baby. So, clinical manifestations, these moms are going to present with either a little trickling or a big gush of fluid. They might even have some bleeding, or they feel like they got lots of pelvic pressure, but they may or may not have any contractions. So how are we going to diagnose it? One, we're going to look at it and say, yeah, it looks like there's a bunch of fluid there, but we're not sure yet if it's a amniotic fluid. So a lot of times we do a Emmersure rupture membrane test that we can do. One thing that's real quick that we can do is a niacin paper or a Fern test. It's a paper that tests pH levels. Urine is very acidic, so urine would be a high on the pH, where amniotic fluid is very alkaline, so it would be very alkaline on your niacin test. So that's something that we would look for. So how are we going to treat premature rupture membranes? It depends on the situation. It's very individualized with each mom. However, if the membranes are completely ruptured, we're probably going to induce labor, because we can't let mom go with that, with the potential for infection. Sometimes if it's just a little tiny leak, sometimes we'll just admit them and treat them for infection, give them pelvic rest, and really monitor those moms closely and monitor that baby. Other ways, we're going to have to go ahead and induce. So it depends on the situation with the mom, but usually if the mom's membranes are ruptured and they are group B positive, moms are going to go ahead and get treated for infection regardless of what it is. So we can, keep track of those babies that way and make sure that our babies are staying healthy and our moms are staying healthy before delivery. So nursing care, everything you're going to do is collect lots of data. Lots of data. Document your data. Follow your healthcare provider's orders. Monitor your baby, monitor your mama, monitor that temperature, report anything that's out of the ordinary, and document that you reported anything out of the ordinary. If preterm labor occurs after 19 weeks and before 37 weeks gestation, it's going to be considered a preterm birth. So preterm labor, these moms are going into labor after the 19th week. So it'd be like 19 weeks and 6 days. Anything before that, it's going to be probably just considered a late miscarriage. So after 19 weeks and 6 days, or before the end of the 37 weeks. So 37 weeks and 6 days. This is your preterm labor. Top things that we want to be worried about, or risk factors that they may have if they've had a preterm baby before, or they have multiple babies in there. If there's more than one baby, that's going to increase their risk for preterm. If they have an infection, that's going to increase their risk, and they might not even know they have the infection. They just come in and they're in labor and they don't know that they have the infection yet. If they have preeclampsia, that's going to increase their risk for preterm labor. If they have any uterine or any cervical abnormalities that could be in, that's going to increase their risk of labor also. Okay, so what are you going to see? What are you going to see when they come in? Well, the biggest thing that you're going to see is cervical changes. You're going to see that the cervix is indeed dilating and it's effacing. Remember the difference between true and false labor? True labor is when we get effacement and we're getting dilation. So the earlier that we can make this diagnosis, the better it's going to be for our babies. So we need to be kind of getting these so we can go ahead and get things going and get things headed in the right direction. So moms are usually going to present with uterine contractions. They may or may not be painful at this time, but they will have some pelvic pressure. It will feel different than those Braxton Hicks. It might feel like menstrual cramps. They might have a really bad backache. All those kinds of things might happen. They may have ruptured membranes, but they may not. They're just presenting and we're seeing those cervical changes and we know something's going on. So how do we diagnose somebody if they are in labor? One thing that we can do is do a fibrolectin test. So we do that fibrolectin test. This test is a test that it's a protein that is inside there that helps glue like that. It's kind of like an adhesive that helps the placenta and the fetal membrane stay together. It's usually absent in weeks 22 through 37. If you get a mom that comes in and she has a positive fibrolectin test, usually that's indicative that she's going to go into preterm labor. So it's something that they could, if they suspect it, then they could be wanting to kind of keep a closer eye on that mom anyway. We also look at the cervical link. If their cervix is short, that usually tells us that they're going to go into preterm labor. So there's a few tests that can maybe help us determine if they're going to go into preterm labor. So those are two tests that can be done. Okay, so how are we going to treat preterm labor? Well, it's kind of going to depend on the cause. So we go back and we look at the cause. What is the cause? We're going to go back and look at those risk factors. Did she have hypertension? Does she have an infection? What medications are we going to use? So if we get a mom that comes in and she's in preterm labor, we're going to use certain medications to help stop that labor. So if you do look on page 390, there's a table that kind of gives us some tocolytics. Tocolytics means that we're going to stop labor. One of the biggest tocolytics that we use is magnesium sulfate, the same one that we use for hypertension. So what magnesium does, remember it stops the muscles from working and they get the low DTRs and they get real lethargic. Their respirations go down. So what it's doing to that uterus is stopping it from contracting. So it's considered a tocolytic. The other one is terbutaline, and I have seen terbutaline given. We can give that one sub-Q or IV. MAG is always given IV. Indomethacin we can give. We don't see it a lot. Nifepride we can give. I've never really seen that one. The two that I've seen the most is going to be your magnesium and your terbutaline. I've seen moms even go home on terbutaline before. If they go into preterm labor, we get their labor stopped. They may go home on terbutaline and take it until they go into labor. So sometimes dehydration can cause preterm labor. So a lot of times we'll come in and we will give them boluses of fluids. Sometimes a urinary tract infection can cause them to go into preterm labor. So we're going to treat that infection and give them some bolus and look at their specific gravity on their urine and see what's going on. So nursing process, same thing. We're going to assess, we're going to collect all that data before we go talking to our physician to know what we got going on. We're going to set that goal for that mom and we're going to implement that plan. And then what would our outcome be? How are we going to get that outcome, the outcome that we want? Ideally, if mom goes into preterm labor, we would really like for her to make it till 37 weeks, but we know that that's not always a possibility if a mom goes into labor at 24 weeks and she has a positive fibronectin test and, her membranes are ruptured, we're probably going to have to deliver that baby. But everybody's individuals and it depends on each baby. So post-term, So we talk about preterm and we think preterm, oh, that's bad, but so can postterm. So this just means that the pregnancy has went longer than it needed to go. So this is after 42 weeks. So this could be from mom didn't go into labor on, usually the physicians like the moms to go into labor on their own. When you go into labor on your own, you have the natural hormones that are ready to take over and they're ready to provide that for mom. However, it doesn't always happen. So sometimes we have to kind of get things going a little bit on our own. So sometimes it can just be from a miscalculation from their gestational date. Maybe mom really didn't know when her last menstrual period was. Maybe her periods were very irregular. But we do know that these babies are a little bit increased for perinatal mortality, which means that babies die inside moms because of placenta insufficiency. That placenta is designed to last 40 weeks. That's its design. That's what it was made to do. And as it works really hard throughout that pregnancy, it gets tired. So we know that placenta insufficiency can be a problem. So we want to make sure we get that done. So common complications that can occur with your postdates, they can have oligohydramnios, which means that they don't have a lot of amniotic fluid. They have less. They have meconium staining, and this is where the baby has pooped inside mom. And then as the baby comes through that birth canal, they can aspirate that, and then they can get that in their lungs. Cord compression, because these babies are big, so they take up the whole uterus, so it can compress that cord. So that's something we want to be careful of. These babies get too big. I mean, these babies are kind of like kindergartners coming out of there, so it's a lot. We can see more shoulder dystocia. We can see more fetal demise. So we really like our moms to deliver at 40 weeks. That's a really nice time to deliver. So if they're going past that 40 weeks, there are complications that we do want to look for. So these are where mom, clinical manifestations and diagnosis is that they're going to come in. If mom hasn't had any prenatal care, we're going to, try to determine her fetal age. So we're going to kind of go in and we're going to look. We may do an ultrasound to try to do they'll look at the long bones. They may do an amniocentesis to try to see what the lungs are doing in there. We may try to do, some checking the amniotic fluid to see if there's any meconium in there, if they've never had any kind of prenatal care. Treatment, just basically frequent testing of the baby, measure their amniotic fluid volumes, making sure that they're staying good and appropriate for that mom. If they're not, sometimes we can do an amnio infusion, especially if there's some compression on the cord. We can do that, or we're going to choose to do an induction. So sometimes the doctors will do biophysical profiles, they will do contraction tests, they will do a lot of those testings, like you'll get one once a week, and sometimes they even do every 3 or 4 days just to keep an eye on that baby. And then once it gets to a certain point, they may say, okay, we're going to have to do an induction, which means we're going to have to make you go into labor. So make sure you know the difference between an augmentation and an induction. And we'll probably get to some of that, but an induction is where we're going to induce you. An augmentation is where your contractions aren't effective, and we're going to give you something to make them effective. So our post-date babies, as nursing care, we're going to make sure, show them how to do their fetal kick counts, make sure we let them know how to do those. We're going to make sure that we're going to monitor that baby, so our biophysical profiles, our contraction tests, our non-stress tests, those are going to be very, very important to look at. If you are there when the membranes rupture, look at the color. What did it look like? Was it cloudy? Was it green? And document everything that you saw. So all of those are things that you're going to do. Okay, intrauterine fetal demise. So this is when a baby dies inside mom at 20 weeks or greater gestation. So this is where the baby's weight is greater than 500 grams or more. That was when I worked in the NICU, 500 grams was our cutoff. We had a baby that was born in the back that was brought to us, and the nurses just come running it in, and we thought it was a joke because they did that a lot, and they laid it on the table, and it wasn't a joke. It was a little tiny baby, and the first thing the neonatologist said, weigh the baby. because if the baby was more than 500 grams, we were going to do everything possible. Less than 500 grams, we were going to let the baby go ahead and die and take it back to mom. So the baby was like 510 grams. So we did everything that we were supposed to do. And when we got the pH back on the umbilical cord, it was really incompatible with life. It meant that the pH was so low that life of the baby wasn't really compatible. So the doctor pulled everything. We took the baby back to mom and let the baby go ahead and pass with the mother. But this is babies that are 20 weeks in gestation or their weight is bigger than 500 grams. This is not the same as a fetal death from a miscarriage, or that early pregnancy loss. This is going to be considered a preterm baby. So causes, it's either fetal, something was wrong with the baby. It was placenta, something happened with the placenta. It could have been abruption. It could have been a placenta previa that pulled away from the wall. It could be all kinds of things like that. So it could be any of those, lots of things. But the most common would be that placenta abruption. Maybe mom fell on some ice and she didn't go to the doctor and there was actually an abruption. So lots of kind of things can happen. Clinical manifestations, usually they're going to come in and they haven't felt movement. So they're going to come in and we're going to find that there's no fetal heart rate. And that usually confirms to us we're not going to be able to find one. Then we're going to do an ultrasound and it's going to confirm there's no fetal movement, no fetal heart rate. So then we know that we have a fetal demise. Those are always the ones I never wanted to take care of because I just never knew what to say. But treatment, basically we're going to induce labor. So as soon as we can, a couple times, sometimes we've sent them home and had them come in like the next morning, like at 5 a.m. to induce labor. So we're going to do the same things for this mom that we would do for any mom in labor, although we can give her whatever drugs she wants because we're not worried about the baby so much anymore. So, but a lot of emotional care, lot of emotional care. Maybe there's a spiritual, someone there in the hospital that can come and talk to those moms, allow them to hold the baby, allow them to take any kind of momentums, like blankets, or if they want to get pictures with the baby, whatever that they need, allow them to do. That's part of the grieving process and helps them to be able to get through that. So these are true emergencies that can rapidly happen. So these are things that you're working in labor and delivery and 30 seconds later, everything has changed. So this isn't something that may come on over time. Some of them come on over time. Some of these are going to be emergencies and we have to deal with them very quickly. So our goal is to recognize them very quickly and get them intervention as quickly as we can. This is where that interprofessional communication is going to come in very handy, where you can talk to your physicians and other nurses around, get things moving that needs to be done. One is an amniotic embolism. An amniotic embolism is where an embolism comes from the amniotic fluid and it backs up from one of those, remember the AVA, artery, vein, artery. This is an embolus coming from the amniotic fluid through one of those arteries out to mom. And it typically likes to lodge in the respiratory system. Just like if we have a DVT, this is just an amniotic fluid one. So these moms are going to present acute respiratory distress. They're going to have cyanosis, they're going to have air hunger, they're going to have hypotension, and they may go into cardiac arrest. These are very acute. Many women die of an amniotic embolism. Some will survive if we have very quick action and the embolus wasn't large. Treatment, there's no cure. Basically, we have to support those vital functions, and we may have to do chest compressions, get them on a ventilator, do the best that we can do. So, nursing care, act quickly. If your mom tells you she can't breathe, that'd be the first thing that you need to be thinking. Let other nurses know what's going on, because it's going to progress within like 30 seconds, we're going to start seeing something change. So, these are they don't happen very often, but they're not good. Shoulder dystocia, this is where the shoulders will not come through. The head gets through, but we can't get those shoulders to get through. So These babies can suffer permanent brain damage because we're not getting them out quick enough and they are in distress. So these are where we can get like cerebral palsy. Cerebral palsy is usually from a birth trauma. This is a risk for both mom and baby. Mom can get lacerations or tears and things in there. So clinical manifestations, they get like this turtle sign, and the attendant's unable to deliver that baby using normal maneuvers. So this baby the head just keeps coming out and back in and out and back in. That's a turtle sign. Out and back in, out and back in. So what are we going to do? We're going to do the McRoberts maneuver, and we're going to do lots of suprapubic pressure. So these moms, we're going to try to push that shoulder down as hard as we can to get it underneath that pelvic bone, to get that baby to go underneath. So nursing care, you can see how that nurse is pushing really hard to get that through there. So first, make sure your mom has an empty bladder. Place on a hard surface under that mom and have lots of neonatal resuscitation supplies ready to go because we're probably going to need them. Sometimes the babies can get Erb's palsy, where they will actually get Erb's palsy in their arm that they had on the side that they had the shoulder dystocia. So just going through the Erb's palsy again, the Erb's palsy is nerve damage when the baby comes through there with shoulder dystocia. So sometimes that usually can go away if some of the swelling goes away. Sometimes it can be permanent. So it's something that we want to always make sure that we're watching for. Okay. All right. So umbilical cord prolapse. This is where the umbilical cord, this is where the baby, I'm trying to look at, the baby is sitting. The head of the baby is right here, and the umbilical cord is underneath, and it may even be dangling down. And that's the first thing that you see, and that is risk. So risk factors, if the baby's in malpresentation, we can sometimes see that because the umbilical cord's able to seep around. If we have multiple babies, because we might have multiple umbilical cords and we don't know which one's which. If we got a mom that's had multiple pregnancies, so there's a little bit more room in there for that baby to move around. If the baby's premature, so premature births means that the baby has a lot more room to move around and that cord has a lot more ability to slip through there. Polyhydramnios, they got lots of fluid in there, so that umbilical cord has lots of room to move around. Rupture of membranes when the baby's in high station. So if you've got a baby that is -3 and their membranes rupture, it's very common for that umbilical cord to go right around that head and come out the vaginal canal instead of the head. So manifestations, you might see the cord, or you might be able to palpate the cord. You see the baby's heart rates going down. Remember the variable decelerations? That's what you're going to see. Remember the VEAL in VEAL CHOP MIND? The V is variable decelerations. And so what happens is this usually can happen right after the doctor breaks the membranes too. So if the doctor does an amniotomy is done to help, it kind of helps augment labor, helps get labor going. So as soon as the doctor breaks that amniotic fluid, you need to be doing a fetal heart rate, making sure that fetal heart rate does not drop. Because if it drops and we start getting variable decelerations, that's going to tell us that we have an umbilical cord prolapse. So that's your VEAL. So what would your CHOP be? Umbilical cord prolapse or cord compression. And then the M in MIND, we're going to move mom. So it depends. So treatment, either an immediate cesarean section if we can't get it back up there. We may be able to move the fetus up and get the baby off the cord, empty the bladder, move the mom, get her in a different position and get that cord back up there. Sometimes we can do that, or it's going to be an immediate C-section. It just depends on what it is. So nursing care, fetal heart tones, that's going to be your most important thing. If you see the umbilical cord, place that mom in knee to chest position. So she's going to get on her knees and she's going to get in that knee to chest position. Call for help. Palpate that cord for any pulsations, because you're going to feel it pulsate because it's going to be moving with that mom. Look at the fetal variability. We might press that baby upward on the placenting part to get it off that cord, but be prepared for that cesarean delivery. If the cord is out, have someone wrap it in some sterile saline to keep it moist. We don't want that cord drying out before it's time. So If one person's got their hand in there holding the baby off of the cord, the other one, if the cord is out, they can be putting it in, wrap it in saline, a towel with saline in it to keep it good and moist until we can get that baby delivered. Uterine rupture, not common, but can happen. So it's usually going to be more associated if the mom has had a cesarean section before and they did a vertical incision. So it's going to go up and down, vertical, up and down. So we would look for that. It could also be from any blunt trauma or medications. What if we had them and they were in hypertonic contractions and their uterus was just like clamping and clamping and clamping, and we did not stop the oxytocin? That can cause a uterine rupture. And this is a medical emergency. The only thing we can do is deliver it by emergency cesarean section. So manifestations, or what are you going to see? You're going to start seeing that non-reassuring fetal heart pattern. So you're going to start seeing those decelerations. That mom's going to have extreme pain in her abdomen. It may be up into her shoulder and back. Blood pressure is going to start going, and pulse is going to rising. And what is that indicative of? Hemorrhage. So we want to make sure we're really looking for that. That baby's going to be in real high station. But the contractions may or may not have changed. And sometimes you can't feel this. You can't really see it. I had a nurse that I talked to. It's been a little while back. She had been an OB nurse for 36 years. And she said, I saw my first uterine rupture. And she said, I knew something was wrong, but it happened so rarely that I didn't think it was that. We call an emergency. She said, I kept letting the doctor know something's not right, something's not right. So we went ahead, and the fetal heart turns were very unreassuring. So they went ahead and took her back to do a cesarean section. They said when they opened her up, there was fetal parts trying to come out of the uterus. It had ruptured. She goes, I'd never seen that before. So it happens, but it's not real common, but it's something that we always have to have in our back of our minds. So again, like this nurse, she recognized those symptoms. She knew with that reassuring heart tone something was wrong. She knew that she had a history of some C-sections. So she's thinking about that. Always think about your moms that are VBACs. So if your moms are VBACs, always think about where was that uterine incision at. And it's kind of nice to go back and look if you have their previous records. You can go see where that was. And usually the OB will have those previous records from their C-section if they delivered someplace else. So we always kind of make sure things are going. So a lot of times in the VBACs, we will give them a trial of labor. And if we see that things just aren't going good, we'll go ahead and do a cesarean section. So just be aware of all those things that can happen and what symptoms and signs that we're going to be looking for. Placenta abnormalities. This would be a placenta acrea. This is where we have an abnormal adherence to the placenta to the uterine wall. And that just makes it where it's not wanting to adhere, it's adhering incorrectly. Okay, that placenta acrea, I just wanted to look something up before I told you. I didn't want to tell you wrong. So this is what I thought. Placenta acrea is where there's an abnormal attachment to the placenta to the wall. So instead of it just being kind of stuck there, the placenta actually invaded into the muscle layer of the uterine wall, and it doesn't want to undo. So this is those doctors that the baby's delivered and we can't get that placenta to come out. That is a problem. And if we can't get it to come out, they may have to take that mom for, an emergency D&C and actually remove it. Hemorrhage is a big problem with that, and that could be something where they might have to have a hysterectomy. So that is something that we would want to be watching for. The vellumous insertions of the umbilical cord, this is where we're looking at where was the umbilical cord inserted. Sometimes it can be inserted on the side of the placenta. Sometimes those placenta vessels can separate in the membranes before they get to the placenta. So there's all kinds of things that we want to know about, and sometimes this can be identified during prenatal stuff, and they will usually know about this. And sometimes these moms are placed in the hospital prior to. My daughter had this, and so what had happened was her placenta had broken into two sections, and so she had a right placenta and a left placenta, and then connecting it was the umbilical cord, but the umbilical cord was not wrapped in any of the Wharton's jelly or any protection. So she was in the hospital for 3 weeks because they did not want her to go into labor, because if her membranes ruptured, the head would hit those membranes and rupture, and the baby would bleed to death very quickly. So in their case, they took her early just to make sure that she didn't go into labor on her own, because they did not want that. And so they took the baby early. So sometimes if you see those, they may take the baby earlier just because of certain things that they know are going on with that placenta. Umbilical cord abnormalities, that's a nuchal cord. And we talked about that nuchal cord. That's where it's wrapped around the fetus's neck. This can be dangerous if we don't know it up front. Usually once the head is delivered, we see the nuchal cord, and we'll say nuchal cord times 2, nuchal cord times 3, and how many times is it wrapped around the neck. The problem with this can be is if the head hasn't came out yet, and as the baby's coming down, it's stretching that nuchal cord. So sometimes I've seen them have to reach up there and try to undo it if they can feel it before that baby's born, because sometimes that it can get really tight, because remember, it's attached to that placenta up in the uterus. A true knot is just where, baby at early stages was flipping around and having a good old time, tied a knot in its cord, and as the baby is coming through the birth canal, it's stretching it, and it stretches it and stretches it and stretches it until it completes that blood supply off. So those are the emergencies that we have in our during labor process. So those are some things that can happen. And go back and look at some of those medications or those tocolytics that we can stop medications. So know which ones we use to stop labor. So your tocolytics is typically going to be your mag sulfate, and it's usually going to be your terbutaline. Those are the 2 things that are going to stop our labors. To augment the labor, if they're in hypotonic, we're going to use that oxytocin. And that is it. Thank you, guys.